Okay, so good evening and welcome to our first of a series of lectures and teachings on ultra wide field retinal imaging. Our teacher, I should say, is renowned, Mr. Simon Browning. He is an internationally recognized expert in ultra wide field imaging. He's had over 30 years experience clinically and in terms of educational experience. He was one of the pioneers in terms of adopting ultra wide field imaging and autofluorescent imaging in primary care. And we're very, very, very lucky to have him with us today and taking us through this journey throughout the whole next 12 months. Mr. Browning, over to you. Thank you so much.
Thank you very much, Ravina, and good evening to everybody. It's lovely to be with you, and can I say it at the outset? I think we have a great year ahead of us, and I'm really looking forward to working with you guys. And just a little bit more about me. It always sounds terrible talking about yourself, doesn't it? But as Bhavina said, I was lucky enough to become involved with ultra wide field retinal imaging almost by accident. I did an eye examination on a member of one of the science teams in Cambridge who was developing something to do with the drive motors for the scan head, and he asked me to get involved. And I thought I was going to go from Bedford a little journey across to Cambridge. I found myself on a plane up to Scotland, and the rest, as they say, is history. Once I saw what was being developed, and I suddenly saw some of the very early images of literally almost a complete retina being imaged, I just saw the immense power that this device was going to have, and the advantages it would bring me and certainly to my patients. So I've been using these systems for 30 odd years now, since the very outset. And as new developments came online, I was able to have some of those developments at the very first outset. Uh, and I was very, very proud to be the first person in the world, literally, who was using in practice autofluorescence ultra wide retinal imaging. And I'll be honest with you, once ultra wide field retinal imaging in autofluorescent mode came along, it revolutionized the way I worked as an optometrist. It changed my attitude and my approach to patients so fundamentally, and it was a brilliant turning point in the career. And we're going to obviously be covering autofluorescent imaging and involving that as we go through the year. So I have lectured. I've been lucky enough to lecture throughout Europe and in the USA, and remotely to Australian optometrists as well. And I've trained teams of USA optometry doctors in Scotland, and I've been over to America to work with a company called Vision Source over there. They forced me to go to their annual conference in Las Vegas at Caesar's Palace, and that was a terrible long weekend. I really had to work hard at that. I've worked with companies like Krog and Seoptic in Scandinavia, very large companies who've incorporated ultra wide field imaging there. I'm a visiting lecturer at City University, but basically now I dedicate my time. I don't practice frontline anymore. I dedicate my whole time to literally lecturing and teaching on ultra wide field retinal imaging, how to get good images, how to use those images, how to interpret the images, and how to take the information we gain from those images and use them to the benefit of the patient. And we either do that in sessions like this, or especially with people who've got instruments in their practice new, I will go in and do one-to-one training sessions with them for half a day or longer. And then I back them up with independent retinal reviews, which people send images to me, and I give them learning from that. So it's like a support mechanism to people as they come into ultra wide field imaging. And within practices, I will train ancillary staff as well, not just to understand the system and be able to promote it to patients, but also I believe all members of the practice staff should be able to take the images for the clinician. And so I train people how to take those images as well. So it's a lot of fun. I really enjoy doing it, and because the benefits are so massive for both the clinician and for the patient, it's a real privilege to be involved. So, as I say, what we're going to do tonight is look at an introduction to the benefits of ultra wide field imaging, and then we've got a series throughout the year. So, the first 5 months, I'm going to do a series of lectures with you, really teaching what goes on behind. So the next lecture is I'm very excited to give this one on autofluorescent because, as I say, this is something that doesn't get covered to a great extent at undergraduate level, but it is such a fundamental instrument in our clinical care of patients. And then we have a series of lectures on black blobs and other suspicious lesions, peripheral degenerations, holes, tears, and the dreaded retinal detachment. So all the while I'll be showing you what images look like, how to interpret images, how to know what's there, and how to take that information and use it for the benefit of the patient. In June, we have a full day face-to-face conference. We'll have instruments there. You'll be introduced into how to use the instruments. If you already have an ultra wide field image device in your practice, then we'll be using tips and tricks to show you how to benefit from that even more as well. And then the second half of the year, we have a series of interactive workshops as well. So by the end of the year, you should be absolutely au fait with the joys of ultra wide field imaging. And by then, hopefully you should have lots of lovely stories coming back from your patients as to where they've benefited as well. So we all know, looking at an eye routinely, this is a good old image. I was hunting the internet today to find some decent images. This is kind of the direct ophthalmoscope area of retina we look at any one time. So when you're using things like direct ophthalmoscopes, which rather rudely nowadays termed the guessing tubes, they give you a very small area of retina which you need to look at, take that information in, build it in your head, and build a montage of everything you're looking at on that retina. And I've done this a few times with optometrists. I've got them to look into an eye, my eye or somebody else's eye, and then 5 minutes later I ask them, I just say, well, actually, just going back to what you saw in that patient, could you just draw what you saw for me? And I think we would all recognize that at that point, what we've actually remembered of what we've seen is absolutely minimal. And this is one of the problems with a lot of these images where you haven't got an image there to go back to. I was looking today also to see if I could find anything about Volk lens, because obviously Volk, great instrument to use. It's relatively specialized, often requires dilation, and it can't be delegated. So if you were busy in your practice and somebody came through the front door with flashing lights and floaters, one of your staff members cannot just pick up a Volk lens and check their retina, whereas with an imaging device, you can image that and get it through to the clinician. They can look at it straight away. The analysis is what I call an at the time analysis, obviously. So you can't look in there and then say, well, I'll come back to that in a couple of hours and have a look at it. And the success very largely depends on patient cooperation, and it's not necessarily suitable for infants. So it's often what I call best possible view in the circumstances. I might come back to this later on. It's a training video from Glasgow Caledonian University, and in fact, it shows you exactly what to look for. If I just whiz this along, you'll see somewhere around here we start getting some views of the. I think it's not going to come on. That's a shame. Okay, well, we'll leave that on. It basically showed us the sort of view we were getting with a Volk lens. I think we all know the amount of retina we're looking at with the Volk lens, and to try and actually look at and take in changes on the retina, sometimes it's not always that easy. So just looking at what we mean with ultra wide field imaging, I've used this analogy for many, many years now. And viewing a retina with standard devices like that, I've always said it's very much like a dentist looking at your front two teeth and sort of declaring, after looking at those two teeth, well, from what you've told me, Mr. or Mrs. Patient, from what you've told me and looking at the front two teeth there, they look great. And from what you've told me, I suspect the rest of your teeth are probably okay as well. And that's kind of what we do a lot of time when we look in the retina. We're looking at a certain area of the retina, and then we're making best possible guesses about everything else based on what the patient's told us. Now, I'm sure if your dentist said to you, well, this is the best possible guess, I haven't looked at the others, you'd probably want him to go and look at the others as well. And this is kind of what we've got here. We spend a lot of our time looking at the retina in the center, but in actual fact, when we actually come and sort of want to look at the rest of it, we're really taking a best possible guess on that. So what we're trying to do with ultra wide field imaging is all the while take us to that periphery, take us into this region where it's all visible to us now. So just going through ultra wide field imaging systems right at the start here, these actually came about because of a chap called Leif Anderson. Now, he was 5 years old at the time, and he lost the vision in one eye because of spontaneous retinal detachment. And his father, Douglas, if you ever get the chance to meet Doug Anderson, he's the most inspirational person. He could not believe how, for want of a better word, barbaric it was the way his son was looked after that, because at 5 years old he had to go to the hospital frequently. They were dilating his pupils, they with nice stingy eye drops, they were anaesthetizing it, putting a 3 mirror lens on his eye and trying to look at the periphery. And Doug sort of couldn't quite believe this in this day and age, that's what was done. But as it was pointed out at the time, that's the technology we have available to us. That's what we use. And you can guess a 5-year-old soon got fed up with that game. So Doug set about developing a machine, and Doug is the most inspirational engineer. And he and his team came up with what was the first Optos system. And as I say, I was lucky enough to get involved right at the start. And over the years, I've seen the progression. And lately, we've had the data. Some of you who remember it from the early days, remember the huge machine we used to have in the corner of the room, and you almost needed planning permission to put it in your consulting room. Well, nowadays, the systems are much smaller. We've developed new systems like the Daytona, the California, the Monaco, and the latest one is the Silverstone machine. And the beauty of the Silverstone machine, I have to say, if I was starting in practice nowadays, I would want a Silverstone. I would make myself find the money for it. Because you haven't just got ultra wide field retinal imaging, you've got ultra wide field OCT as well. So you can literally OCT right out to the oris serrata if you want to. It's a stunning breakthrough, it really is. So there's your family, and we started with what were called pseudo color images, and they're still the main set of images that a lot of people use. And pseudo color is using a red and a green laser to come up with your image color. But lately in the California and the Silverstone, we have true color images as well. And the Optomat family are very much ultra wide field imaging systems. Now, there was a lot of disagreement over what we meant by ultra wide in the early days, but the definition that is now accepted is based on sort of physical markers within the retina. We're all very good at using physical markers. We'll say something's 2 disc diameters from somewhere else, or 3 disc diameters from the macula and what. So we use these physical markers. So with a wide field definition, we're talking of the area between the center of the retina and the vortex vein and pulley. Ultra wide field means outside of that area, so from the vortex vein and pulley out to the oris serrata. But this is in a single capture, and this is the true definition of ultra wide field. It has to be in a single capture. Now, some devices nowadays, the new players in the market, they talk about ultra wide field. Ultra wide field is obtained by montaging images together. You still get out there eventually, but it does require more than one image. But the important thing is we are getting out into the periphery. But you can see with the Silverstone here, you've got autofluorescence, fluorescein angiography, infrared, indocyanine green angiography. These are very, very popular in eye clinics nowadays. And a lot of eye clinics are now looking out from secondary care into primary care in their community to see who are using these ultra wide field devices, because the hospital is now using them themselves. So we're built the momentum on ultra wide field imaging is building all the time, and I think last year with the advent of Boots opticians starting to use ultra wide field images in all their practices, it's brought a new sort of sense to the game because many more places in primary care are using them. And we've seen over the years the building of more and more papers, some just looking at whether ultra wide field imaging is as good as traditional methods. And we see those developing over time. And all the while, the papers are saying better, better, better. But so many clinical research papers now rely on ultra wide field imaging as well. And this one caught my eye a little while ago. We all know macular degeneration takes place in the macula. Well, what we're now beginning to understand with the benefit of ultra wide field imaging is macular degeneration does not start in the macula, it starts in the retinal periphery, and it can be seen much earlier in the periphery. And sometimes you can intervene when you see these peripheral changes to delay or even prevent macular changes happening. Very exciting project. And obviously in the news yesterday, we were talking about blood tests being used to find early Alzheimer's changes. Well, we also know the peripheral retina shows signs of amyloid plaquing in patients, and there is a great future for detecting early Alzheimer's in the peripheral retina in years to come. And in fact, 10 years ago, I said that as cures come on board, optometry would probably end up being one of the first places we would diagnose Alzheimer's in patients. And that to me is still one of the most exciting things that is going to form part of our future as a profession. More papers here come up, and this was interesting. We're beginning to see phrases like ultra wide field imaging devices showed non-inferiority to the gold standard. So again, we're beginning to see that this is now becoming a method of choice for looking at retinas, easily as good as Volk lens and 3-mirror lens. And I'm going to be showing you some images later on that back this up. And again, here we see later papers showing, more and more evidence that peripheral imaging steering, peripheral steering should be considered as a standard of care for detecting peripheral retinal breaks. Ultra wide field imaging may be used as a screening tool. And so for telemedicine and things like this as well. So all absolute good reasons for being there. So ultra-wide field imaging, it gives us the opportunity to view areas of the retina not normally looked at in a routine eye exam. So, that's kind of an area you would see in an eye exam there. Routinely, you've got images like this occurring for every patient you see. And where I have my staff imaging these for me in practice, the patient would come into my room. I would have these images already up on my system. So I'm immediately looking at their retina. And this is the sort of image you would routinely have to look at. There's a greater chance to view peripheral retinal changes. So again here, there's things happening in the center. What's causing it? We can immediately see the cause of that change in that retina. And there's greater opportunity to view changes within a retina in context with other structures. So often, again, when we're looking with a direct ophthalmoscope or something like that, or even a Volk lens, we're looking at a very restricted area of retina. So with the traditional view, we'd just be looking at that part in the center there. But you can now look at those other changes on the retina relative to the other structures within the retina and the relevance they play to those structures. So I want to share with you now a scenario. Now, this scenario came to me when I was training some of the optometrists in America. And this was just a sort of a daily occurrence in a clinic where we had a 23-year-old came in for a sight test, totally asymptomatic. They were there purely and simply because their work had sent them. There were no problems with them at all. Excellent visual acuity, plano both eyes. It's the sort of patient you dream of in the middle of a busy day because you can get through them and get them out. And the question was, well, what method would you view their retinas? And there was a kind of split in the room, partly between direct retinoscopy, direct ophthalmoscopy, and a Volk lens with an undilated pupil. But then the question was asked, how would you explain your results to the patient after that? And I want you just to spend a second thinking, well, okay, you've got this perfect patient sat in the chair, absolutely nothing wrong with them. You look in their eye, you see nothing wrong. What do you say to the patient? Because so often at this stage, the explanation you give to the patient is, well, I'm really pleased to say I've looked inside your eyes and everything looks really healthy. It's great news. There's nothing wrong. You can go away and we'll see you again in 2 years. Uh, and that's fair enough if that's what you thought happened. But do you have any evidence of where you looked in that eye? That was the question that was being asked. And what do you say to the patient? Well, as I just said, the main thing people say is, well, everything's fine and well, great news for you, all's good. So this is how we left this patient. And I think it's fair to say that probably happens up and down this country, day in, day out, many, many times. And you could almost say there's nothing wrong with that at all. The problem with this patient is she came back 6 weeks later and she told the receptionist that she wanted you to know she'd had emergency treatment in her left eye for retinal detachment, and that vision was now really quite poor. And she goes on to tell the story that after a few days after visiting you the first time, she'd noticed some flashing lights, but she thought, well, this can't be to do with my eyes because she'd been to her optometrist. He had said the eyes were absolutely perfectly healthy. So she just ignored it and assumed it was a migraine and, thought, well, it definitely can't be in my eyes because he'd looked inside my eyes and he'd said everything was absolutely fine in there. So she ignored it, and then a few days later, she lost the vision in the eye, and that resulted in the retinal surgery. So all she's done today, she's just come back to your practice to ask for copies of your records of that sight test, confirming, because she wants to confirm that everything you saw at the time was okay and was normal at the time of the test. And the question that was put to the room was, what do you do next? And words like panic came out, or consult my lawyer, or things like that, because the feeling was it's only when it goes wrong that you realise that you probably haven't got a lot of evidence there to say what you did. And if you said to the patient, I've looked inside your eye and everything is fine, you've left the patient with the thought that you've looked at the whole of the inside of the eye, when you may not have looked at the whole of the inside of the eye. So that's a little scenario that I think is always worth considering when we stop and look at what we do with patients in the light of what we may or may not see. And just to back that up with a couple of live stories here, this patient, you can see from the scan here, the image looks a bit ropey. Well, this was taken on one of the very earliest Optomap devices. And this was in my practice, and this was a high myope. She came in and she'd come in for a contact lens check, actually. She was about -9 and she was wearing gas permeable lenses. And she said, oh, I hear you've got this fancy new fandangled camera. She said, it sounds wonderful. Can I have a go on it? And this was the image my staff member took at the time. And you can see immediately on this left-hand side here, a very large flap tear in the retina. She was completely asymptomatic. She wasn't aware of the large floater. It was just there. And this was, as it always is, about 5 o'clock at night. I ended up putting her in my car and driving her to the emergency eye clinic, where they attempted a retinopexy, didn't work. And so she was actually transferred to a specialist vitreoretinal unit where she had cryotherapy the next day. But she had no idea there was anything wrong. None of us had any idea there was anything wrong. And it just showed us that. Now, this is a different person. In the latter stages of my practice, I actually amalgamated my practice with another one in Bedford. And the other practice wasn't doing ultra-wide field imaging of any sense at all. And the chap there said to me, what is this about ultra-wide field imaging that's so good? I said, well, pop up to my practice and I'll show you. So we took an image of his eye, and as you can see there is a tear in the retina. Now, my mouse is playing up, which is annoying. I can't get the mouse to work. But you can see in that top left-hand corner there is a flap tear in the retina with a fluid cuff around it. very strongly associated with an area of white without pressure, and actually sitting right on the vitreous base. And the vitreous base is where the vitreous is most firmly attached to the surface of the retina. So you've got a lot of vitreoretinal traction in that area, and that had torn his retina. So sent him to the eye clinic. The eye clinic looked with all their conventional devices and said, no, nothing wrong there. Don't worry about it, you'll be fine. And it's only when he showed them the image on his phone that they then had another look and found his tear and immediately carried out a laser retinopexy on him. And that was less than 24 hours later. You can see the results of that. Looking absolutely superb. The retina's no longer under threat. The macula's not under threat. Move on. But he was completely asymptomatic. He had no idea that was there at all. So again, just a simple look with ultra wide field takes you out there routinely. Here's another chap with an early cataract. Again, a retinal tear. And again, we were able to simply treat that because we were able to look out there very quickly, very routinely. So let's just spend a few minutes looking at how we take good images, because obviously this all depends, the way you analyze an image and the results you come up with all depends on taking good images. And I think this holds true not just for ultra wide field imaging, it holds true really for any imaging device. When you first set the patient in front of it, do not rush. I always say at this stage, the slower you go, the quicker you'll be. Because you probably all know, as soon as you say to the patient, I want you to put your chin on that chin rest, they're there like a shot. They're stuck in there and they don't hear another word you say because they're too busy thinking, what's he doing next? What's he going to do? And they don't hear you. So get the patient to sit back, get them to understand what you're going to do and how you're going to do it, relax and talk it through slowly. I got there continually practice lid manipulation. A lot of people used to worry about eyelids and eyelashes getting in the way on images. If you routinely lift the top lid out of the way when you're taking an image, you will do away with lashes almost completely. And I think some of the later devices, like the California, that now use a chin rest when taking images, you'll see from the image I'm about to show you that things have vastly improved on that, and really eyelashes are not an issue. And then I say continually practice eye steering, because again, although these are ultra wide field images, by getting the patient to look up, left, right and down, very, very commonly you can get out to pretty much the ora serrata, if not the ora serrata itself, again, without using dilation. And I always say continually practice on easy patients. And that means that when the difficult ones come along, they're actually not difficult because you've done it so many times before. Because typically with life, you know what happens. As soon as you need to see somebody, they're always going to be the hardest ones to image. So use your practice staff, get your practice staff to practice on each other and to practice on you, and basically have some team time when you're all learning to take good images. And as I say, that stands for all pieces of equipment. Now, there are ways of looking at patients. They'll tell you what's the best optimum distance to have them from the machine and everything, but always look at the facial characteristics of your patients. Our little friend on the left here, he is not, if you tried to take an image of him at the optimum position, you'd get really poor images because he's just going to be too close because of those eyeballs. His big advantage is his eyelids and eyelashes will not get in the way, but you're going to have to hold him further away from the machine. His friend on the right here, much, much deeper set eyes. You're going to have to get him much closer in. So again, look at your patient when it comes to taking the images to decide exactly where you're going to need them on the machine. With all devices, but especially with the Optimap devices, you get some very, very good literature with it. So you can make use of this, read the literature, and also lots and lots of videos available to you. So look at the videos, take the videos and watch them carefully, go through piece by piece, again, with your practice staff, and you will learn very, very quickly the basics of image taking, and then practice, practice, practice. And you have crib cards obviously here, which you can use with the patient when you're in that sort of relaxed phase with them, to show them exactly what to expect when they get into the machine. Because once you get into any diagnostic machine, it's always difficult to remember exactly what you should do. But for successful image analysis, you've got to have good images. If you've got an image coming to you and you feel it's not good enough, you must request new images. You should never attempt to analyze an image on what we call the best possible guess from image sent basis. If you don't like the image, if you can't really get a good view, then you cannot use that for analysis. You must get good images. Always make sure you take two basic images. The idea of this is to remove artifacts. Again, you can see on this image here, this is rather lovely because you've got the ora serrata on this temporal side here showing very, very nicely. And those basic images will give you different depths of the retina to look at when you come to analyze the images. So the image on the left there is looking at the retinal surface. The image on the right is looking further down at the RPE choroidal interface. So that depth analysis gives you a very good opportunity to judge what is going on within the retina at the different depths. And then the autofluorescent image. Now, as I say, I'm not going to talk too much about the autofluorescent image tonight. That's the next lecture. And this is the one that really, really excites me, because here we're looking at these images are looking at the structure of the retina, whereas with autofluorescence, we're looking at the actual functionality of the retina. And much more information there. And then again, if you've got something going on in the periphery of the retina on your initial scan, we want to eye steer to go further out in the eye to see what's happening further out in the eye. And you can see with these eye steered images, pretty much a lot of the time we're getting out to pretty much the ora serrata. So here's a beautiful image. This is a classic. Patient sits the machine. This is the kind of image you can expect each time. Now, a lot of people ask me what this circle is on this image. Well, that's the vitreous base. And the vitreous base, very, very important part of the eye. That is where the vitreous is most firmly attached to the retinal surface. And the area where, when we start seeing vitreoretinal traction and PVD, the area where so often, most likely, tears and holes and things are going to appear. So vitreous base is something that's there in everybody's eyes. This one, it's particularly clear to see in this eye, but again, it's a marker that we really should be looking for in a lot of eyes. And this is quite often the sort of image you will get. Now, this one, yes, you can see the vitreous base nice and clearly, but really you've got to try and re-image this patient, because you can't really take anything too meaningful out of an image of this quality. And this is a 3-year-old. Now, ask yourself, when was the last time you had a view of a 3-year-old retina that clearly? And again, the beauty of imaging is we're not looking at this live time. You can take this one shot and then you can leave little Johnny to go and wreck the rest of your consulting room whilst you're having a good look at his retina. And again, this is so important to be able to have a look at this stage. Remember Leif Anderson right at the start. He was only 2 years older than this lad when he lost the vision in his eye. Had we known the state of his retina a year before, maybe he would have never have lost the vision in that eye. So again, for youngsters, ultra wide field imaging is very, very easy to do, and you get images like that. And as I say, this was actually the first ever autofluorescent image taken. And I took this in my practice. The machine had literally only been installed 10 minutes. And this chap was completely asymptomatic, nothing wrong with him at all. I was quite chuffed with the way his retina looked. And then I did the autofluorescent image, and it told me a completely different story. And that's all I'm going to say about this, because next month we will go into this image and other images in much more detail. And I can tell you what this autofluorescent image is telling me. And it's very, very important, this image. There's some little changes on there that are going to be so important to this person in the next 10 to 20 years in terms of him avoiding macular degeneration. So very, very exciting autofluorescence. So let's look at some reasons why we use ultra-wide imaging and the benefits it brings to us in the practice. So what I've done here is these are patients all who were asymptomatic and weren't aware of any problems, and some of them had been seen before and told there were no problems at all. So here's our first patient. I'm sure if we looked at that, we'd all, as a fundus photograph, we'd all be really happy that was pretty good going. When we go ultra wide field, again, we see a lovely view of the vitreous base, but we also see a rather large lesion on that lower nasal quadrant. And in the coming lectures, we're going to go into how we would analyze an image like this and how we work out exactly what we're looking at. This incidentally is a true color image that we get nowadays, but you can see from the different depths here, you can hardly see that image there, but you can see it very clearly on that image down at the choroid RPE level. So again, these images immediately tell you something about this patient and about where a lesion is, and you can then arrive at conclusions as to what you're going to do with that. And we're going to go through things like using the mole system on this for analysis and all sorts of things like that we've got lined up for the future. Here's another patient. Now, this patient, this is an image, again, using a fundus photograph setup. And this patient had been told there was nothing wrong with their eye. And what you're about to see, you're going to say to me, well, nobody would have missed that. But they did. And you do not want to be missing things like that in an eye. But if you go in and you've got a patient who's telling you there's nothing wrong, and a cursory glance around with a direct ophthalmoscope can lead you to say, oh, there's nothing wrong there. Unbelievable though it may be, that was missed. And that is, again, a rather nasty looking lesion there, and you don't want one of those. Again, asymptomatic, no dilation. This is quite an interesting person because, again, you can see some floaters down here, and these basically suggest there's a Vices ring there, which probably leads you to jump to the conclusion that there's PVD going on here. But again, if we go ultra wide field, we see a completely different story. There's another lesion on the retina there. When I mentioned this to this patient, I said, well, of course, you know, that's been there basically all your life. And she said, well, I've had so many eye tests in the past. Nobody's ever mentioned it to me at all. And quite often when I go back and contact previous optometrists and say, can you just confirm this is on your records? Never is. It's never been seen. So again, another lesion there that really should have been spotted. Asymptomatic, no dilation. And here's another one. And we've got a retinoschisis there. Now, again, the textbooks say retinoschisis, lower temporal, normally bilateral. No, they're not. You can often get them just in one eye, not the other eye, and they can occur at any part of the peripheral retina. And it's really important to understand what's going on at the different levels. And it's really important to make sure that you've got no holes in the upper and lower surfaces of that schisis. And there are various techniques for doing that as well. But again, you can see with the ultra wide field image, you get the bigger concept of that, and you can see the whole lesion in one foul swoop there. So you can take in that information far better. I showed you a chirpy just now. That's the autofluorescent image of that. I showed you a chirpy just now. Here's another chirpy, but you'll say to me, chirpies are pigmented. But chirpies lose their pigment over time. So quite often you'll look at a lesion on the retina. And again, looking at this with a Volk lens, it's not that easy to work out what's going on here, because again, you may not see the whole lesion all at once. Whereas with an ultra wide field image, you can see the whole lesion at once. And when we go to the autofluorescent image, we see it's completely black there. This is a depigmented chirpy, just for fun. So an awful lot of chirpies actually lose their pigment completely. And so they're much, much harder to see and recognize. But again, the autofluorescence is your giveaway guide there. Once again, asymptomatic patient with no dilation. And here's another one. This was a patient who, again, hard to believe, but they weren't aware they had a problem. But when we go and look at the autofluorescent image, immediately we can see that very large flap tear up at 11, 12 o'clock there, and the resultant retinal detachment coming off down the temporal side there. These sorts of patients, we immediately send this image to the eye clinic. There's no messing about, straight to the eye clinic. The clinic is phoned, confirmed they've got the image there, and the patient is sent to the specialist clinic. We got to the stage in my clinic where if I said a patient had a retinal detachment, they did, and the clinic would know they were coming. And if you sent this ahead to the clinic, then they're ready for the patient, and they're ready to sort of treat the patient. So again, looking at the different layers of retina there, you can see it looks different in different directions. And you can probably see on this here, and we have another one showing in a minute, you can see the loss of clarity of the deep choroidal vessels underneath that retinal detachment. And that's a sure indicator that you've got fluid there. And again, we're going to go into that in far more detail in upcoming lectures. Now, lattice degeneration is an incredibly important thing to know about. Lattice degeneration occurs in about 10% of the population. And it's probably the definition's changed recently, and I think you're going to find it occurs in much more than 10% of the population. And the other vital thing here is that about a third of people who have retinal detachments have lattice. So if you've got a patient with lattice degeneration, the probability of that retina tearing and potentially detaching is very high indeed. And it's really important that all your patients who have lattice degeneration know they've got it, so they know how to react if something happens. Maybe in the snowy, icy weather we've had recently, they fall over and bang their head. Or, I don't know, maybe they take up paddle and get an eye injury by being whacked in the head with a bat. There's been papers written on that recently. It's such a big rise in percussive injuries. Maybe they play football on a Sunday league game and they head a ball. All these percussive injuries, people with lattice can have a tear in the retina. So they need to know it's there. They need to know the risk factors. So if you think about 10% of the population on average, if you're seeing 10 patients a day, probably once a day, you should be talking to patients about the risk of their lattice degeneration developing. If you're not having those talks, maybe you're missing lattice degeneration. But this is why they need to know. This guy hit his head. Having hit his head, he came in to see us straight away for a routine check because he thought he'd begun to see some little changes. And you see there a new hole and a very obvious retinal tear there. Because of he knew what to do and he came and saw us straight away, straight down to the eye clinic, retinopexy, treated, sorted. This was a very interesting one. She had been somewhere else because she had noticed some floaters, and they'd very helpfully taken a photograph of her with a retinal camera. They spotted the vice ring and they said, "Oh, brilliant news, it's a vice ring, so the jelly of your eyes peeled away from the retina. You're fine. We'd expect that this at your age. You're absolutely fine. Don't worry about it. If you do see any sort of flashes or anything, you better come back and have another look with us. But there shouldn't be a problem because, you know, the vice's ring says it's okay." Well, she had been to see me 10 or 12 years before, and then she'd moved to America. So when she got this advice, she wasn't too happy about it. So she came in to see me, and this was the ultra wide field image we took. And we can see the vice ring just below 6 o'clock below the nerve head. But there's something happening in that upper region around 1 o'clock there. And you can see the slightly distorted blood vessel there. Now, as soon as you get anything going on in the periphery like this, it's pretty obvious what could be happening. We eye steer these patients to get even further out. And again, by eye steering this patient, you get the answer. A big tear in the retina there with lots of fluid leaking through that tear, and that retina is detaching at a rate of knots down towards the macula. But if you look over the other side, there's also another hemorrhage there. And if you look at 3 o'clock, you may just be able to make out something very subtle going on in that image there. So again, if we look at the different depths, you can see in the area where that fluid is, again, the way those choroidal vessels are blurred out. But let's look at the other side where that hemorrhage is. You can see that same sort of blurring going on there. And again, if you look towards the 3 o'clock side, you can see a bit of blurring there. So this referral turned from this patient's got a retinal detachment to this patient's got a triple retinal detachment. And that upped the ante massively with this patient. And again, we send the images to the eye clinic and they saw the patient, cryotherapy and scleral buckle, and Bob's your uncle. Everything was sorted. But this patient started their journey by having a retinal photograph taken with a retinal camera and being told, "Don't worry about it, there's nothing wrong. In fact, the news is good." Quite the opposite of what the ultra wide field imaging showed us. And again, this patient needed no dilation. This image was taken and literally within 5 minutes we've got the answer we need, and this is being sent to the eye clinic as an image, and it's being downloaded onto the patient's phone so they can take it with them as well. This chap, again, 48 years old, self-employed, really stressed. He's getting lots of headaches for quite a few months. And again, he had a test somewhere else. They'd done a fundus photograph on him there, and they said, basically, you need a holiday, matey. You're stressed out. So he came to see me. We did an ultra wide field image, and there's the melanoma that was missed. Again, ultra wide field imaging, no dilation, it takes you straight there. And really, we should be seeing this all the time. This one, if you watched the darts recently, you might remember there's a chap in the semi-finals. He got to the semi-finals. I think Luke Littler beat him. He had dominant optic atrophy. That shouldn't be, it shows it's not a handicap, but you can see the sort of levels of vision. This woman had dominant optic atrophy, and her image showed something that I've been referring to for many years as a boggy spot in the retina, right in the periphery again. This was taken quite a few years ago before we routinely eye steered everybody. And you can see these boggy spots. Now, the reason I call them boggy spots is that I've seen so many of these over the years. And when the vitreous begins to peel away from the retina, they tear. You get a flat tear time and time again. And again, these sort of boggy spots, these would now come in under the definition of lattice degeneration generally. But the second you see these, the patients need to be aware in case anything happens. And I want to just show you these images here. This is ultra wide field OCT imaging. And it's just completely changed the way we view what goes on in the periphery. Just look at the amount of tractional forces that are at play on that peripheral retina with vitreous detachment. I mean, literally, if I took the back of my hand and really yanked on it and pulled it right up, that's what's happening between the vitreous and the retinal surface. And the problem is the retina's much, much thinner in the periphery. We're all used to seeing the sort of macular pit get yanked right up with vitreomacular traction. Doesn't happen in the periphery. It tears the retina in the periphery because it's so much thinner. So when you think of the retinal periphery, just think of the amount of tractional forces that are going on there. And this is what happened with this woman. We got her to come back. She was a chef in a restaurant, very, very busy. And she'd noticed this wafting for about a week. And when she got a gap in her schedule, she came back to see us. And we got a large retinal tear, flap retinal tear there. So immediately sent her off for treatments. That's it being a bit of eye steering going on this time. We sent it off for treatment, and she had a laser retinopexy. Now, I don't know what you think of that retinopexy, but one of the analytical tools we've got here, we can put the retina on a 3D wrap. And if you line up the nerve head and the macula there, you can see that retinopexy is hardly worth bothering with because it just doesn't go the whole way round. Q, a very intriguing letter back to the ophthalmologist, sort of along the lines of, love the work you've done so far. Do you intend to complete it at any stage? And we got a very fun letter back from him, but he immediately did cryotherapy with her and sealed the thing. But again, ultra wide field imaging allows us to get to look at these areas and look at the treatment that's being done. Now, lattice degeneration. As I say, I commented on before, these are sort of standard retinas you see with so many people. You can see the pigmentary change there. You can see the retinal holes. Now, we're going in future lectures, I'm going to go into much more detail about the significance of retinal holes, different types of retinal holes, and retinal holes versus tears, retinal holes versus lattice degeneration. But we're going to look at different ways of analysing this and seeing what's going on. But once you see this in a retina, you must look at the rest of the retina. And we go eye steering with this. And just look, that eye steering shows there's so much more degeneration in the upper half of this retina. And the patient just must be aware of it all the time. Look at the other eye. Always check the other eye. So often you'll see the same sort of thing. I've got a friend locally in our village. He had a retinal detachment due to lattice, and he was off work for a while, got back to work, carried on for a little while, and then I heard he'd had a retinal detachment in the other eye. They hadn't actually looked at his other eye when he had first eye surgery. He had a lot of lattice in that eye, and he had a detachment in that eye as well. But interesting enough, there's another little thing with this case. We've got lots and lots of lattice degeneration going on here. But also in this eye, you've got just adjacent to the macula and just under the macula, you've got two nevi there. Now, again, ultra wide field imaging where we can look at the different depths brings us a whole new world of nevi. I did two studies on nevi where we just counted up the number of nevi we saw in patients in a routine clinic over a week. So one consulting room, 1 week, just under 90 nevi in that week. We followed that up about a month later and we hit just over 90 nevi in a week. So, you should be seeing certainly 70 plus nevi, I would imagine, routinely in a week. Fortunately, most of them don't cause a problem, but they all have the potential to be nasty. So we need to know they're there. And so if you're not hitting somewhere 70 plus nevi a week, you're then once again, very much like lattice, you're probably missing them. So I want to touch on diabetic retinopathy as we sort of move towards the end here. Diabetic retinopathy is an incredibly important thing where we need to be looking at the periphery. And ultra wide field imaging lets us do this every time. You're probably aware of the fact now that if somebody has been found to be so-called normal in their screening for 5 years, then their screening interval now goes out to 2 years. The problem with diabetic screening is we're not looking at very much of the retina at all. And if you talk to your diabetics about just how little of the retina is being screened, they're quite alarmed, a lot of them, because they assume if they're having their retina screened, they're having all of their retina screened and not just a little bit of it. And again, this is another group who really do not understand what we're doing with them. But just because your patients might be in a screening program, it is absolutely vital that we know what's going on in the periphery. You can't just say, well, just because the screening says you haven't got any diabetic change, we can just ignore it. We need to know what's going on. So if we have a look at this patient, this was a patient who'd been graded R0, M0 and was on a 2-year recall. Well, it's hard to believe that they've been told they haven't got diabetic retinopathy, because there is a mass of diabetic retinopathy there. But they're on a 2-year recall. I've lost count again of the number of times I've written back to a GP practice and to the primary diabetic team in that practice saying, your patient is on the wrong recall interval. They need to be seen far more frequently. And a patient like this needs to be in the diabetic clinic in hospital for a full diabetic review. They really need fluorescein angiography and the full works to see what's happening. But often these diabetic patients are not compliant. They'll tell you they are, but they really need to be seen by the diabetic team for full follow-up and for further analysis. But as I say, if you just sit there and look at the centre bit, you just are letting the patient down. So we must know what's going on in the periphery. And you'll see so many studies coming out nowadays. You see this, the second one there, peripheral lesions identified on UWF imaging predict increased risk of diabetic retinopathy progression over 4 years. There are so many papers here that are looking at the progression of diabetic retinopathy over time. And it's so important to understand that periphery. So again, here's another one. Is this a diabetic patient? Not according to the screening service, it wasn't. This is a perfectly healthy, normal person, until you go and look down in the nasal side there. You've got obvious signs of diabetic retinopathy there. This person needs to be under more regular review. Again, when you look at the image of the surface of the retina there, you see the diabetic changes and the exudation happening there. This patient should not be on a 2-year recall. So as we come to the end, I just want to sort of say, well, why should, hopefully you've seen from these images why it's a benefit to the patient for you to be able to see routinely what's going on in the periphery. If you are using a device in practice every day now that routinely gets you out to beyond the vortex veins and out to the orbis serrata, then fantastic. It probably means you're dilating every one of your patients and you're an absolute supremo at Volk. But, if you're not doing that, then, this is why I invested in ultra wide field imaging techniques, because they're so important to me as a clinician, but for the patient as well. And I'll be brutally honest at this stage. Financially investing in Optimat was one of the best moves I ever made, because what it did to my profits was incredible. Uh, and I couldn't understand why anybody would ever turn it down. But the commercial decision was far outweighed by the massive improvement in patient care. And hopefully these images have shown you just what can happen there. Um, on more occasions than I can remember, I've been thanked for saving a person's eyesight, which is lovely. Some of the best moments come when somebody comes in and says, "Thank you for spotting the tumour in my eye." I had one chap who he was told he had a melanoma, and that was confirmed. It was a macular melanoma, and that was confirmed by the oncologist. The chap bought me 12 bottles of champagne. He was so happy. And I thought, thank you so much. Interesting response to a melanoma. But I think my most beautiful moment was when I had a lovely lady come in. She said that her and her husband had known each other since sort of kindergarten, preschool, and they were childhood sweethearts. They'd grown up together, they'd married, they'd had children. They were now in their 80s. And she said to me, "He's too young to die and leave me. Thank you for saving his life." We'd found a melanoma in his eye, and you will be meeting him again later on in the sessions. That's why I became an optometrist. And I had a locum once who she came to me and met ultra wide field imaging for the first time. She told me after one session that she didn't like the ultra wide field device. It was no good, because whenever she took these images, she kept finding things on patients' retinas. But then when she looked with her Volk lens, they weren't there. And so the ultra wide field device was just no good because her Volk lens was better and she could never find anything with it. So it had to be the device that was wrong. I have to say, she didn't do any other locum sessions for me after that. But it's interesting when you go to the United States, you see the newly qualified optometrists who are setting up their own offices for the first time. They come into the exhibitions and things to buy equipment, and top of their shopping list is not an OCT, it's an ultra wide field imaging device, because they see the value of that. Because the OCT will give you more information about stuff you've already looked at with your Volk lens or with your direct ophthalmoscope or with your retinal camera. What the ultra wide field device does is take you to places you've never looked before and you see them for the first time. And so this is the most important thing they buy. I had a student come up to me once. I'd just done a lecture at the Karolinska Institute in Stockholm, and she came up to me after and she said, "Could I come and do a year training with you under the Erasmus scheme?" Do you all remember the Erasmus scheme? Been in the news recently. I tell you, it was fantastic. I'd never heard of it before she came to see me, but she was a brilliant optometrist, and she was with me for a year, and then she went back to her home country of Estonia, and she's only ever worked with companies with ultra wide field imaging devices since then, because she is not comfortable with the limited view she gets with other devices. And my last little one to tell you, I had a student come to see me who was working. She was a student at a university. I'm not going to say which one, but she finished her first year and she came and worked with me for the summer. And we had her doing ultra wide field imaging all through the summer and showed her about it and everything. So I got an email from her about a month and a half into her second year. And she told me she was actually thinking of giving up optometry, because they were doing the bit where they taught you how to look in the eye and look at the retina. And she was really frightened about what she couldn't see when she looked at the retina with the devices they were using. And they didn't have an ultra wide field imaging device at the time. And she couldn't see how she could practice and look after her patients without it. Anyway, we got it carried on, and she got a good degree. She did a pre-reg year, and she now works with ultra wide field imaging devices in practice, and she's a very good optometrist. So hopefully this opening evening has given you a sign of what ultra wide field imaging brings to the consulting room, and why we need to be looking in the periphery, why it's just so important nowadays. And then what we're going to do in future sessions, as I say, is drill down far more into what these images are and what they're showing us, and how we can analyse it all. And as I said at the start, I'm just really excited to be working with you guys on this. So So hopefully that's whetted your appetite for the rest of the sessions. I'm going to wind it up there. And what's happened whilst I've been doing this is my mouse has decided to stop working, which is why I can't get the cursor to move anything on my screen. So I can't get my chat box back up. Uh,
Uh, I have,
so
I can answer that. There are actually no questions in the chat at this stage. I'm going to invite all our attendees. If you have any questions, then please do take yourself off mute. Your cameras are all off. You're all on mute at the moment, but please do take yourself off mute and ask a question if you have one to ask. More than welcome. Thank you so much, by the way, Mr. Browning, for your talk today. It
my
has
pleasure.
taken appetites. Obviously, we have practitioners on today who have the ability to make some decisions in terms of purchasing and equipment. We also have some practitioners here who work in practices who may or may not have access to the equipment. And obviously, you've mentioned that in the future, we'll be looking at drilling down the interpretation element of things, and looking at how we look at these images and what we take home from these images and what we can learn more in terms of about the peripheral retina and its health. So that is one of the elements that I wanted to raise to our participants. Did we have any questions?
What
Oh,
what I would say as the sessions go on, that if you do have any questions or anything and you want to ping them to me, you've got my email there and you've got my LinkedIn contacts there. So if you want to if you want to contact me otherwise and ask me questions they can't, please do feel free to do that as well.
yeah, absolutely. And likewise, if you have any questions and you're not sure of the contact details, then get in touch with me, or through the WhatsApp or through an email, what works. There's a
Yeah.
couple of questions that have come up.
Yeah,
Can we
I've got
refer
I've got
to?
them up now actually, Praveen.
Okay.
I hit my mouse quite hard and it seemed to respond. Um, can we refer to ATS another for ultra wide field imaging? Yeah, I mean if you know of another optometrist in your area who has ultra wide field capability, then there's absolutely no reason you shouldn't. In fact, one of the things that used to happen a lot in my practice, we would take a patient through their exam. We'd talk them through what this machine was doing that other devices wouldn't do. You'd be amazed how many times we had a phone call from one of their friends within the next 24, 48 hours saying, all my friends talked to me about this machine they've got on, blah, blah, blah. Can I come in and have some images taken with you? Now, obviously,
Absolutely.
that's quite okay to do. That doesn't enter the realms of a site test and all the legal obligations of a site test. It's quite acceptable to just image a patient. We would get them in, we'd image them, and again, I completely lost count of the number of times we'd see things like chirpies or nevi on a retina, and you almost very sort of tongue-in-cheek say to somebody, "Well, of course you knew about that, didn't you?" And they never did. They were never aware of that. Um, I would probably say as high as 95% of those people actually converted to being patients of ours on the strength of that. Now, that's not to say that if you refer a patient to another clinician that they're going to poach that patient. We never once attempted to poach a patient, but the patients themselves see the benefit of what we can see. It goes back to this dentist analogy right at the beginning. Once they know that they've only had the front two teeth looked at, then they see that you've now got the capability to look at all those teeth. That's the dentist you're going to go to. I
Yeah.
don't know if you've seen these dentists who have this machine that will actually x-ray every single one of your teeth all at the same time. Brilliant device. I love it. And it's kind of like ultra wide field dental imaging. It's the same capability. And the patient goes, wow.
Yeah.
So yeah, it's so yes, please do. And I think anybody who's got an ultra wide field device will be very, very happy to see your patient and then refer back to you. There's no problem with that at all.
If I answer sort of a more local update, so we are soon to be running the imaging platform through our COTS program, and that does also include ultra wide field where it's available. So you can refer into the COTS, even if you are a COTS practice, you can refer into that for imaging with wide field if that's what you feel is important for your patient. So
There's another one on here. I'm trying to decipher it actually. Patient
patient
declines
decline.
Optos,
Yeah.
not want to pay for Optos as you miss a detachment, melanoma, whatever. Patient goes blind. How do you stand legally? Patient declined. Um, I think what we're looking at here, obviously, you have to have consent for a patient, and I think this is one of the things that I spend a lot of my time teaching in practice. Is of course, a patient can decline to have an ultra wide field image. And a lot of patients decline because they don't want to know if there's something wrong. It's natural in an awful lot of people. But what I find with an awful lot of people is that they most patients, if you say to them about looking inside their eye, they assume we look at the whole of the inside of the eye. Now, I've got several bits of paperwork and information we give to people that says, well, this is what we would see if we looked with this device, and this is what the Optimap enables us to see. And some of the examples I've shown you this evening are kind of things that we would say to people about how we can see this, but you can't see it with this device. And it just gives us the opportunity. And I have to say, I use the dental analogy so much of the time because people get that dental analogy so easily. And an awful lot of people, uh, once they have understood that what we're doing allows us to go to places we've never seen before, they change their minds. And you'll find a lot of optometrists actually build this in as a routine. But in fact, there's one optometrist, some of you may know him up in Scotland, and he literally has a sort of 3 and out system where if they don't want to pay for it the first time, he says, that's fine, don't, but I'm imaging you anyway. Second time, don't, but I'm imaging you anyway. And the third time, he says, look, you clearly don't want the standard of care we give you here. Here's a list of other optometrists in the area. Please feel free to visit any of them. And he's been doing that for over 10 years now. And he's got something like about a 99% take up on the system. Once people understand it, then you find the decline rate is actually very, very low. I'm not quite sure what we're saying about the if you miss a detachment or melanoma. What you've got to remember is that detachments and melanomas, if they are in an eye, whether you image them or not, they're there. And so, nobody misses them on purpose. But I think whatever way you look at an eye, you've got to be able to put down on a patient record what it is you've looked at, the area you've looked at, and the conclusions you've come to. And you've got to almost have on the record card patient aware of limitations of these observations. Because if you've not made the patient aware that you've only looked at 40, 50% of their retina, the patient will walk out thinking you've looked at all of it. And yeah, there can be a problem there legally, but provided you said, I've looked at, the device I've used tonight has allowed, or today's allowed me to look at 50% of your retina, that's kind of what goes on throughout the whole of the profession. That's what we use, and that's the limitation. But based on that and what you've told me, these are my observations, then, that's fair enough. But I think if the patient has declined and you've done your best and you've made a note of all of that, then fair enough. But I have to say, in reality, I find the vast majority of people do take the opportunity, and it's no skin off my nose to actually take an image the first time to show them the difference, and then that's where they then say, oh, I didn't realize that that's all you saw, and I understand now how much of an improvement that is. And so it's all to do with education a lot of the time. And that's why it's so important to have the practice staff on board as well, because the practice staff can do an awful lot of that education as well.
Yeah, I completely agree. Is having the whole team behind it and understanding the importance and relevance of it, and
Yeah.
then talking that through. Yeah,
I
amazing.
mean,
Um,
one of the things that often, sorry, Bhavine, one of the things that often used to happen, people would come in and we'd do an image on them, and then they'd come back a year later, and I'd say, so we're doing the Optimap on you again this time. And it's more a sort of statement than a question. They say, oh, I don't want it this time. You did it last time. And
Mm.
that always used to be an interesting one to get round. And I found whilst I was practicing, most times you could get away with most things provided you smiled when you said it. But if they said, well, you did it last time and so I don't want it this time, I would normally sit them down in the site testing chair and I'll put the trial frame on and then I'll take it straight back off again. So we're not going to do this. We did it last time. And then they'd sit there and say, but something might have changed. And you just smile and say, that's why I wanted to do the Optimap as well. And I would honestly say there was probably as high as 99% say, yeah, ooh, silly me. And they'd have the Optimap. So it's the way you approach the patient and the confidence with the patient. They come through that door for one very simple reason. They trust you. They would go somewhere else if they didn't trust you. So they trust you. And I always say this, I mean it so sort of fundamentally. They walk through that door because they trust you with the most precious sense they possess, their eyesight. And when you just stop and think about that, that's one hell of a responsibility, isn't it? And it's an honor to be able to do that. So, I just look at them as a challenge sometimes, or most times actually.
That's brilliant. Right. It looks as though there's no more questions in the chat. I'm gonna just pause our recording.